it's always great coming back to Grace. I've been a part of Grace for the past 1 year as a patient ambassador, and I'm so happy to continue this work. And this is actually the second blood OncTalk that I'm a part of, so it gives me great pleasure to be here back again and talking to you all. So the last time we dealt with some basics of multiple myeloma and touch base a little bit about CAR T therapy. Today, I want to talk about a little bit about bispecific antibody therapies in multiple myeloma, specifically some updates we've had in 2023, because compared to, let's say, early 2022, when we had no FDA-approved options in the market, right now in September 2023, things are quite different, and we can go over them very quickly. So again, just to refresh everyone's memories, including patients and caregivers, now multiple myeloma is the second most common blood cancer. And what it actually is an abnormal number of plasma cells that multiply in the bone marrow and that interferes with normal functions. Plasma cells essentially are white blood cells that becomes very specialized to identify and fight infections and cancer by producing antibodies. Some of the symptoms of multiple myeloma, which people may be aware of, include having anemia, kidney injury. It lowers your immunity, have unexplained weight loss, and it directly affects the integrity of your bone, causing fractures. It can cause holes in the bones, and also when all the calcium from the bone kind of leaches out to the blood, it causes high calcium levels, which again can go back and damage the heart and the kidney. Multiple myeloma presently in 2023 is largely considered an incurable cancer. However, it's a very treatable cancer in 2023 with all the agents we have available. And therefore, because of its incurable nature, we need continuous therapy in almost many cases to keep the myeloma at bay. The way I sort of explain to my patients is that you have to have your one foot on the gas pedal at all times. When you take your foot off the gas pedal, there's a high possibility that the myeloma can grow back, which we don't want. So we kind of hit it with some kind of therapy all the time. Now, the landscape of immunotherapy in multiple myeloma has changed quite differently in the past 5 years. Now, when we were treating multiple myeloma 5 years ago, we relied very, very heavily on conventional chemotherapies and stem cell transplantation. Immunotherapy is a type of treatment that uses the patient's own immune system to kill cancer cells, and instead of directly killing cancer cells like the chemotherapy that we all know of. Just going into the broad categories of immunotherapy, and I'm only highlighting here the ones that are FDA approved. One include targeted antibodies, including monoclonal antibodies directed against anti-CD38 or anti-SLAMF7. These are some drugs you may have heard of called daratumumab, isatuximab, and elotuzumab. Bispecific antibodies, they're also antibodies, but unlike the monoclonal antibody, which only attaches to one particular protein, bispecific antibodies, by the name bi, meaning two, they go ahead and attach to two different antigens or proteins. And we'll talk about this more as we dive deeper, but this is just a quick overview. There are two main targets on the myeloma cell called BCMA, that's B cell maturation antigen, and GPRC5D, which now have products that are FDA approved and in the market ready to use anytime we feel that a patient is appropriate. The two anti-BCMA bispecific antibodies that have been approved are teclistamab or Tecvayli and elranatamab, which is Elrexfio. The anti-GPRC5D CD3 bispecific antibody is called talquetamab or Talvi. And lastly, there's the adoptive T-cell therapy or the CAR T-cell therapy, of which two BCMA-directed CAR Ts have been approved, which is ide-cel or idacaptogene vicleucel, and cilta-cel, which is ciltacabtagene autoleucel. Again, the focus of today's talk is mostly going to be bispecific antibodies, but it would be quite remiss of me if I don't have this one slide overview of CAR T options in myeloma, which are so important to many patients also. Now, in general, when we talk about CAR Ts, we are vastly talking about autologous CAR Ts, meaning we take the patient's own cells, manufacture them in the lab using genetic engineering, make them express some antigens that are like giving them a sort of magnet or a sword to specifically attack myeloma cells, and then give it back to the same patient. That's called autologous or self. Now, in autologous, the two therapies approved include those directed to BCMA, which is idacaptogene, which was ide-cel, which was approved in 2021, and cilta-cel, which was approved in 2022, early 2022. There are some experimental targets that are very promising, including GPRC5D, SLAMF7, CD38, and FCRH5. And keeping all that aside, there's also researchers are now working to develop allogeneic CAR Ts for multiple myeloma. Allogeneic, as the name implies, would be a donor, T cells derived from a healthy donor that are manufactured in the lab and are ready to go when a patient needs them. Again, these are all in the experimental stages and we don't have them quite ready for prime time yet. These CAR Ts are approved for patients who have progressed beyond 4 different types of treatment.